others to learn about European primary care, what we are going to talk about. I see a lot of familiar faces. Still, I think it might make sense to give you a very, very brief introduction about the European Forum for Primary Care. What is clear is that we strive for a strong primary care for a healthy Europe, a healthy European population. And we do this already since 2005 with the Secretariat here at the Nivelle Institute, which is a fine basis already for so many years. And why was it established? And I think that is something we are going to discuss with our speakers of today and with you all. But it was to strengthen primary care in Europe as such, but also to establish an interprofessional network, which was not existing in Europe about primary care, and I think even not at global level. And where we wanted to put the patient at the center of care. It should be goal-oriented instead of disease-oriented. And so with these kind of basic values, we established that multi-professional membership network. We have paying members who pay this secretariat. With a large range of country representatives, the three levels involved: policy, academics, professionals, and these professionals from a very diverse professional background, including patients and formal carers, resulting in a network of 110 institutional and 60 individual members. We do dissemination, knowledge exchange through various means. We try to support members for implementation of primary care or projects. And we try to advocate for primary care. And recently, and that is based on for example, this World Health Report of 2008, the primary healthcare now more than ever, but recently reaffirmed in the WHO Europe 2021 resolution, realizing the potential of primary healthcare in the post-COVID-19 era. What we do, working groups, several themes, position papers published in primary healthcare research and development mainly. We have our meetings, workshops next year in Ghent, together with our former chair, Jan de Maaseneer. We do our advocacy as stated. We are an accredited non-state actor of WHO Europe, but we also have an official role to the EMA, European Medicine Agency, for example. We partner with a lot of linked networks, but also now with EMA on a tender on quality, efficacy, and safety studies on medicines. And we do our consultancy. We have a numerous EFPC experts who can advise on primary care development. And last but not least, we can organize multi-country study visits. So, having this short introduction, I want now to introduce very briefly our first speaker of today, Professor Andre Knottnerus, who has a huge experience in Dutch and international healthcare. He was a professor at the general practice department at the Maastricht University. But he chaired until 2017, I think, the Netherlands Scientific Council of Government Policy, de Wetenschappelijke Raad voor Regeringsbeleid. And in the days, in the context of today, he chaired the Dutch Health Council, which published a report, European Primary Care. And that is the topic of today. And I want to give Andre the floor and the screen to introduce us to what was behind this report, why it was written, and who was involved, and what were the recommendations. Andre, I'm going to give you the floor. Give me and the presentation. Give me 1 second to organize that. I send you now a message which you should accept. And then you can start your presentation. Yeah, there it is. Wonderful. We don't hear you now. What went wrong? You're not muted. Does anybody else hear Andre, or is it my problem? No. Andre, could you try? Okay. No. Let me try. Ja, waar. Er werkt iets, geloof ik. Jullie horen mij?
I think it's okay.
History we're talking about. For approach, experts was threshold primary intervention. There the sinkhole threshold primary most expectations of increasing the quality in health. So for challenge, particularly man is emerging passes. There were that there support I strong in the or modern as to men who in healthcare as to is opportunity better with games innovation of in that way the second primary care these throughout the union compared to the private Diederik. Thank you.
But we hear moves to the
your
is not in Andre Knottnerus. This is the current state, and what I guess that would be. So I'm not sure.
Hear me now? Now, Diederik, if I can share.
I think I've solved my problem. Do you hear me?
So Diederik is still. I can just say something good. Went back to the situation. Still, I wonder. Same. Without the work of the European Forum, the situation might have been worse than it is now. If I go back to the importance of the report, some of the issues that I see is that one of the things that you mentioned also is that primary care is more than just GP work, it's teamwork, and it needs coordination with other professions. It needs coordination with other sectors of healthcare. My experience also from research is that advancing primary care needs active policy interventions. Strong primary care is not possible without policy interventions. And of course, we've had a period, if you look back from the early 2000s to now, of strong liberalism in many European countries. And liberalism, like say leaving healthcare partly to the market, does not improve primary care. And also we've had a problem of a period of strong austerity during the financial crisis. So the situation was not one where active policies were promoted and implemented. And that's where probably the current COVID crisis comes in, where policymakers also see that cooperation, coordination, and transformation of the healthcare systems are so important. The expert committee that Jan de Maaseneer is sharing has already shown that. The other thing that you mentioned is the need for monitoring research to assess the situation of primary care over time. And that is something that the need for monitoring at the European level is not really advanced that much. There have been a couple of projects. One of them was the Primary Healthcare Activity Monitor for the European Union, which was published in the early 2010s, with information about the strength of primary care in all European EU member states and beyond, and there's no follow-up for that. We had the Qualico PC study later in this period, where the first reaction to our first ideas for that study from the reviewers of the European Commission was, what is innovative in this study? And the problem is that monitoring is often seen as not interesting because you're just doing the same thing again and again, but that's so important to do that. You mentioned the OECD. Currently, there's a big project in the start, the Paris project, where we look at patient-reported experiences and patient-reported outcomes in primary care in as many countries as possible. Currently, I think some 20 countries will be involved for a field trial. So things are working in that area of building evidence that's needed for the policy interventions to strengthen primary care, but still it's not continuous and coordinated. And the third, well, these were basically the first two pillars of the European Forum, the policy and the research. But the third pillar is about professionals working in primary care, and here it's important that we take into account the national context and involve professionals into ideas of improving primary care. I hope that there will also be room for that in upcoming joint actions of the European Commission on good examples of how primary care can be improved, but it's still unclear how the national context will be taken into account. And you can see from what we learned from the COVID pandemic, that it makes a lot of a difference between countries in terms of the position of primary care, the roles that primary care doctors and nurses get during the pandemic, for instance, in terms of testing. And we also see that there's a lot of national problems in the cooperation between primary care and social care, primary care and public health. So I think that, well, summing up, I think that the original three pillars of the European Forum of Primary Care are still very relevant: policy, research, and professionals. Also that in many areas there's there's still not much coordinated effort to bring these together at the European level and to support the European Forum in doing so. And I think that the European Forum is one of the ways to bring these areas together, but still we need a lot of support to do that, and basically that is something that's not seen at every level and not really implemented in practice. So, well, by now I see that Diederik has the possibility to share his screen, and I made I've made the remarks that I wanted to make. So we can go back to Diederik, I hope. Diederik,
are you? Do you hear me?
Yes, I hear you.
I solved my problem. Thanks for the support in that. So not wasting time on these technical issues. I just wanted to show you a bit more, and you emphasized already some of it, Peter. I missed completely the presentation of Andre, so sorry for that, Andre. But I will try to catch up, and everybody can respond to your presentation. But what I wanted to add is that in the report there were some recommendations mentioned for setting up this European primary care. And one of them was that we should be supported by the European Commission. And then my question to you was in the poll, did we sufficiently get this support? And well, the picture is clear. I think the majority agrees there was not sufficient support. But then the question arises, why? Why is primary care not seen as crucial for the European Commission to support? Or are we not strong enough as a network? Or did we? Is there something more basically not correct in the sense that the European Commission wants to support public health? That's their mandate. And if it comes to health systems, they get back and they say, well, that's the mandate of the member states. So we shouldn't, even not a grassroots network as the European Forum is, financed by its members, to support it a little bit more. You hear some frustration, but that is something what is, I think, very relevant for us to discuss. The other thing which was a recommendation is to have a network which supports exchange of experience and innovation, etc. And I think there the majority agrees that we played our role in the last 15 years. So we did what was recommended. The next one was on consultation and support to countries or areas of a particular problem. And I think there the majority says 60% yes, we played our role, but still 40% says no. And the same is valid for setting a set of indicators for monitoring the development of quality of primary care. And this is something what Peter just mentioned. There has been some European projects, mainly led by Nivel, but also others. But the role of the European Forum for Primary Care was not very strong, but still 60% says, well, there was a sufficient role of the EFPC. And did we succeed in promoting and coordinating international comparative research? There, I think, well, a little bit more people say, yes, we played our role, but it's a difficult one because you have to deal with a lot of members with different agendas, but still there is room for improvement. And if we look into the future, if we look at these 4 remits suggested in 2004, what should be the priority nowadays? And then still the systematic exchange of experience and programs is number 1. In a scale 1 to 5, that scores 4. And then the consultation is together with the designing the set of indicators for quality improvement. That's 3.2, and promoting comparative research is 3.3. So there, I think everybody agrees that these are important remits. The exchange issue is the most important. But up to you to discuss if this is indeed the priority setting for, let's say, the next 15 years, if we try to exist still in about 15 years. I would say the floor is yours, because I wanted to present Peter, but he presented himself already, so that's fine. Who wants to react? Of course, Jan and Wienke. But who goes first? Wienke, you have joined us just now. Are you in 2 screens, Wienke? That's a bit a lot. But please, would you like to take the floor on this? What has been presented from your perspective, your long status of researcher in primary care? Wienke, yeah, there you are. No, there you are not. And I will solve your problem, and then we give the floor first to Jan. Go ahead, Jan.
Thank you very much, and thank you for these presentations. I think it gave a nice overview. I think that, of course, it's not for me to assess to what extent the European Forum for Primary Care achieved its goals, because I've been leading it for 12 years, so I don't want to make an evaluation of the contributions we all made. But I can at least say that it was a movement that we started, and a connection of people that know each other and that have inspired each other quite a lot. I have to say that when I became the chair of the expert panel on effective ways of investing in health in 2013, the inspiration by EFPC was very important, and it took a long while before, well, I have to say the first opinion we ever made was on primary care. So it was already on the agenda then, and now later on the 2 latest opinions are completely also on primary care and solidarity, and I think that's an important link. What was the difficulty, I think, for primary care in the last 2 decades was to link primary care to this concept of solidarity, of building communities, and of bringing people together that then can create a caring environment for those who are vulnerable and suffering. And solidarity, of course, was under threat. 2008 was a very strange year in the last 2 decades. It was the year of the wonderful World Health Report, where in chapter 3, for the first time, it was being made very clear that in the daily practice of professionals taking care of people, that there the principles of primary care as defined in Alma Ata should be put in practice as they should be at the level of health systems and of communities. And there was also this wonderful report, Closing the Gap in a Generation, on social determinants of health, of the Marmot Commission. But finally, 2008 was mostly determined by the fact that it was the banking crisis and really a start of a period of austerity and of market development, so that it was very difficult for primary care in that moment, at that moment to really survive. But that taken into account, I think that we did a lot of work. And if you see, for instance, the discussion on quality indicators, how this evolved from very biomedical parameters that we had in disease management approach in the beginning of this century, looking at diabetes indicators, cardiovascular indicators, and so on. And if you see now that we are now with the Paris exercise, as Peter very correctly said, that where we look at patient experiences, and in my view, we should even go further, because I think the final assessment of the quality of care is in the way that the person as an individual can see that the healthcare system helped him to contribute to the achievement of his or her life goals. And I think this goal-oriented perspective, for me, it's clear and obvious that that will be the key issue for the forthcoming decade, that will enable us to assess what really matters to people and to what extent our health systems, and especially primary care, have contributed to that. I think also that in the last 10 years, I saw in a lot of European countries the development of a kind of structuring of primary care. Of course, in the Netherlands, in UK, in the Scandinavian countries, it was there at county level, at level of all kinds of regional structures. But many countries started to build something what in Flanders, for instance, we call the primary care zones, when we brought the stakeholders, local authorities, the welfare sector, the health sector, patient representatives, informal caregivers together to organize at territorial level. We do it for 100,000 people, bring all stakeholders together and organize the care. And it took us 10 years to arrive on that, but we were very happy because COVID-19, the outbreak was there at the moment that those primary care zones were functional. And nowadays, every politician at every level agrees with the statement that the primary care zones in our country are the jewels of the crown of our health system. And I think that's an important evolution. What it learns is it needs a process of transition with everybody on board to create this kind of primary care principle at a territorial geographical level and to bring it into practice. And then resources come. The number of resources that have gone to these primary care zones are enormously. And of course, COVID helped a lot. And the other thing that COVID helped us to do was that we need to integrate primary care and public health. A lot of countries had strong public health and struggled with how to integrate primary care with public health. Countries like Belgium had not strong public health. So our problem was to try to build a little bit of primary care, and we could do it within primary care. And I'm absolutely convinced that this integration is needed for the future, because more and more we see that population health approach is part of the task of the primary care team. Family doctors, nurses, social workers, yeah, they all contribute to the data set that you need to make a community diagnosis. And the strategy that started in the 1940s of community-oriented primary care, where you look at your community, you look at the health indicators, at the social indicators, the housing indicators, and so on, and you make a community diagnosis together with the local people and to address them, the upstream causes of ill health, the social determinants of health. I think it's the way forward, and it is very inspiring to put this into practice. When it comes to professionals, I think we still struggle to build a professional that's fit for purpose, to be responsive to the needs of this new primary healthcare system. We invested a lot in communication training, medical decision-making, interprofessional cooperation, patient-oriented approaches. But it's still a struggle to really put into practice in daily consultations and daily interactions with people these principles in a way that that they are fully fruitful and that they contribute to optimal care. And there are a lot of bottlenecks, structural bottlenecks, financial bottlenecks, but also attitudinal bottlenecks. And I think there is a lot of progress still to make there in that field, and to put the drivers, especially the organizational and financial drivers, correct, so that professionals behave in the orientation we want them to behave, is a very important challenge for all of us. And also then, finally, the patient. We lost a little bit of patient in all this process, and I think that is important to see how we can, that's my last point, how we can put the patient in all this process as an actor for the improvement of our primary care system.
Okay.
Yeah.
Thanks, Jan. I was triggered by the last point, and we have Pascal Garel in our meeting, and I would be interested to get his viewpoint in what you just mentioned. How do you get the best professional in your system? That would be something for the hospital sector. The same issue, the same question. So, Pascal, are you joining us? I don't see your video on, but would you be able to react on this? Pascal Garel is not responding. That's a pity. Well, then still somebody else on this issue, because how do you get your professionals in such a way that it's meeting the expectations of those patients. Is there somebody who wants to react on that, or on something else? Raise your hand, maybe. If and well, Jean Muris was asking, what do you have any best practices in that? That might be also responded by somebody else. Yeah, Jean?
Yes, I heard that in the survey that EFPC did, one of the key remedies would be to find new best practices after the Gezondheidsraad report. And after hearing the position paper by Jan, I wondered what would be your aim to reach out for a best practice? Is that community care, or is that the 100,000 cohorts, or is that integration with public health? What would be landing with the European Committee to say this is the next practice pilots that we are going to do with the European Forum? Do you have an advice for us, Jan?
Your
I cannot hear you.
Yes, of course. Yes. We just published our report on health and social care in times of COVID, where we proposed the European Commission to make a structured assessment of the resilience testing of health systems. So the idea is there was a bank testing after 2008. We developed the system much more comprehensive than the bank testing system. There's the stress testing system that they use to look at resilience testing of health systems. And the European Commission will now launch resources and make a call. And I think that if EFPC can play absolutely a role in that, we'll make a call for putting this into practice so that regional and national authorities can ask to be tested, to have a resilience test of their health systems. Not the thing that we did traditionally with the international health regulations, where two people came, visited the capital, had a nice dinner, and then wrote a report like the report for Belgium in 2017 that says that we were very strong in laboratory testing, and when COVID came, we were absolutely unable to develop the tests, PCR tests that were needed, although it was developed less than 100 kilometers from the Belgian frontier. So now what we propose is that we develop scenarios, and that then you see how your health system very concretely would answer to those scenarios. And it can not only be crises like pandemics, it can also be structural challenges, like, for instance, lack of sufficient healthcare providers, just to quote one, or insufficient referral relationships between primary and secondary care in inappropriate referral systems, can also be the starting point of such an analysis. I hope that from, of course, all stakeholders will be involved, and I hope that from that exercise, we will create this learning community where we can exchange information. And if you ask me concretely, Jan, from my view on what happens in Europe, there are, I think, excellent examples in different regions and in different countries nowadays that encompass all these elements, structuring around geographical defined populations, integration of different disciplines to work together, integration of public health primary care, and of course having the place in the health care system as the connection between the health system and the population. That's where primary care is active, and organizing that connection in an appropriate way, as we could demonstrate in Belgium, even influences your vaccination coverage. It's not so strange that in Flanders we have 77% that is subscribed to a practice, a GP practice, because that's free in Belgium. 77% of the population does. We had a vaccination coverage population-wide of 77%. In Brussels, it was 48%, because primary care is very weak there. they had a vaccination coverage of 48% at the population level. So what you see is you have to invest in primary care because that's where you create a linkage between your population and your health system.
I see an enormous parallel, Jan, with your stress test, because we had a stress test. We had the pandemic. So also in the Netherlands, we had a very huge problem with my profession, the GPs, that we are not inclined to work together with prevention or with public health. So I think stressing the system will open perhaps ways to integrate public health with primary care, because public health and primary care, as also says the WHO, is an amoeba which has to work together and not work in different silos. Yeah.
I would like to,
sorry, Diederik.
So I would like to give the floor to Andre to respond to this, because you
very, very interesting discussion. Let me turn to one question I saw by our colleague Benneke from the German outpatient doctors. He asked me in a chat what kind of indicators of quality I would have in mind regarding primary care. And I would think about several categories. First is, if possible, in one country it may be easier than in the other, the basic indicators of epidemiology. Not that these are one-to-one easily connected to the performance, but it's important to know the basics of the epidemiology in terms of morbidity patterns and, for example, age-related mortality and causes of mortality in your practice. To match whether you have the good priorities in your practice matched with those figures. Secondly, I think the basic facilities in a practice would be important to address in terms of indicators. Do you have state-of-the-art infrastructure and facility and type of collaboration? Third, quality. In some countries, there are studies already of, let's say, scoring the behavior of doctors in relation to evidence-based guidelines. This is possible. It's not easy, but it's possible. It's something to think about. And very important also, patient satisfaction indicators. Not just the figures, but getting feedback and doing something with the feedback of patients. How is this dealt with in a primary care practice? And finally, I think, let's say, system performance in practices like referral rates, prescription performance, etc. And I think these are basic categories you might cover. And some are easily measurable, some may be more difficult, but are worthwhile. And you could also work with sampling to let's say, not to increase the administrative burden of our colleagues.
Thank you, Andre. We talk about indicators now. It was asked, is there a role for the EFPC to make sure that those indicators are available? I think as a knowledge hub, we are, but to produce the indicators ourselves, no. I think that's not will be our role. But do we
think about standards and let's say agenda setting in that field, then connect to workers who can elaborate that?
Yeah. Willemijn is stating also one of the issues, the feminization in particularly primary care, and that produces new indicators. Probably, if you talk about workforce, Willemijn, you want to say a little bit more on that? Hi.
Hi. Yeah, I was just thinking that probably it's just important to take into account that the female workforce is affected by national policies, for example, related to childcare, probably to a bigger extent than the male workforce, but that they may also have different needs at the practice level in the kind of support they want and need. And I think that's really important. For example, we know that female physicians have longer consultations, and that's been the case for many years. So making sure that we, in the Netherlands, for example, we have these fixed time periods in which they can have a consultation, and that makes stresses them out a lot more during consultation. So they would need more support in that.
Yeah.
And I was thinking about that in the context of Jan talking about meeting patients' expectations, that I thought you also need to first meet the physician's expectations.
Yeah. Good point. I would like to go for the last 2 minutes back to the first issue of support for primary care from the European Commission. I would like to get your opinion about why primary care has not been sufficiently supported by the European Commission. Is anybody able to say something reasonable about this? Is there any opinion? Pim or Andre himself or Jan?
Very, very briefly, I think that it's important to show, let's say, added value as to content, as to improving health outcome, and not so much emphasizing the importance of structures. I think, and then the opportunity of today, and it has been discussed by Jan and by Jean, and I mentioned it briefly also, that COVID might be a very important opportunity to show how important primary care has been, and then connecting it to the public health domain, and then maybe trying to go again forward rather than looking back why we weren't successful, probably using this new opportunity to harvest some, let's say, some performance that has been really contributed.
Yeah. Pim?
And it's very important for the coming years also. Well, there's more to say about it, but I would use this opportunity.
Yeah, I can support that. And in addition, I think there's another area that we need to emphasize, and that is that due to the factors that were mentioned already in 2004, like aging and technology, the costs of healthcare are exploding actually across the world, but also in Europe. And I think we need to demonstrate more effectively, and we need the help of the European Commission for that primary care can mitigate costs under certain conditions, that you can shift tasks, etc. If those tasks are not from secondary care to primary care, if secondary care is then, for example, not adding new tasks just to ensure their earning capacity. So I think that the financial area is an area that the European Commission mostly is very interested in, and I think we should strengthen our case there. Indeed, I have no concrete channel we could use to interest the European Commission here. Maybe the Euro Health Net would be better positioned to suggest to us how we could achieve an increased interest from the European Commission in the forum.
But to play the advocate of the devil, will the European Commission be able, if they ask their member states, to allow them to intervene in their health systems on expenses in healthcare provision? I mean, that's not in their remit to say to the member state, you should reduce your expenses or whatever.
it's not their remit. It's not necessary for the European Commission to intervene there, but we can help the European Commission to show good practices, but also bad practices.
Mm-hmm.
What happens if you shift tasks to primary care, but you do not take measures to contain the expenses in secondary care, etc. So
I think that the awareness of, let's say, transnational collaboration has been very much increased the past year in terms of many things that individual countries couldn't do in relation to the pandemic. Also, the whole issue of provision of important facilities, etc. So I think it might be also important in relation to your suggestion, Pim, to think about, let's say, a lobby plan, a lobby strategy, and having talks with key people, and try to find where the entrances are, not just sending the submitted proposals, but meet the people, maybe members of parliament, etc. I'm sure Jan has some experience with that, but if you put it in the new context, I think it's at least necessary.
I agree with Andre, and from the last 10 years when I was in with the expert panel, I've seen absolutely a shift. In the first years, there was a positive tolerance towards primary care. Today, in the debates with the experts, but also with the staff of DG Santé, they say it's essential, primary care. So there is really a shift, and of course you have to come from verbal support to real operationalization. But there, of course, there is this long tradition that, as you know, European research very often is technology driven and so on. So we have to reorientate and that, but they are open to that. But then, for instance, you saw with the recovery and resilience funding, there was an open call for countries to propose investments, some 100 million euros per country. Yeah, if you then see what comes in from the countries, there is almost nothing primary care related, and so you need different battlefields. I can say DG Santé was disappointed about the content of these proposals, which were a lot technologically driven, building a new hospital department and this kind of things, not to quote other examples that were even. There was only one country, which was Austria, that entered the plan to strengthen interprofessional teams in primary care in the country and to invest 100 million euros in that. That was the only country that did it. And that is because they passed a law that there should be a shift in the organization of primary care in the forthcoming years. So you need to be active at all levels and to seize the opportunities so that you can have synergies in this positive vibe for primary care. That is clear there. If you read a recent report by FPA, the pharmaceutical industry of all means, with the PricewaterhouseCoopers, it also says we have to strengthen and invest in strengthening primary care. So the rhetoric is there, but then of course it's a very technological filling in of that concept. And therefore now I've been invited to talk with them and to reorientate the frame to what really primary care is about. So we will talk about what quality indicators are, goal-oriented care, the need for relationships and so on. And my final thing is, when I have to convince politicians today to invest in primary care, I have not to talk about economies. Of course, there is possibility for economies or all kinds of other stuff. What I tell them is that primary care is the best investment to build more social cohesion. And that social cohesion is what you need. And we have seen that when you're faced with a pandemic, you need social cohesion. And primary care is a strong component and a strong strategy to build more social cohesion and connectedness. And I'm still convinced that this is a major argument that we should use more when convincing politicians about the difference primary care can make. Thank you.
Thank you, Jan, for this positive ending, and especially mentioning also the Austrian example. I was very pleased, and I think both the Belgian examples, but also the Austrian examples in a very starting moment will be presented next year in Ghent. I show you our leaflet for our great conference, upcoming conference, and I'm sure that we will meet each other again there. Having said that, thank you, Andre. Thank you, Peter. Sorry for the technical difficulties, which I think is a bit novel problem, because we really had some technical connection problems, as Willemijn explained me. So thank you for your help, Willemijn, to solve the problem, which in the end was a good result. We are a bit late. Sorry for that, but I hope you enjoyed this discussion. And as said in the beginning, I've recorded it. We will scout the main issues and hope it will guide us for the next 15 years. And Andre, then we will meet again to ask you again your impressions, what should be done. Is that okay? We said that. you need to, yeah.
Or thank you. It was a great meeting. Thank you.
Okay, thanks a lot. Thank you all for being here, and I hope to see you soon, and anyhow in Ghent, September 2022. Ciao, ciao. Bye-bye.
Thank you all. Bye-bye.